Welcome to the podcast for Healing Neurology, where we really talk about everything that can help heal your neurology, which is really everything from food, lifestyle, and medicine to nature, culture, and politics. There's no topic too big or too small. I'm Jillian Ehrlich, family nurse practitioner, certified in Ayurveda and functional medicine. And we have a pretty fun guest today who is a physiatrist. So Dr. Virtaj Singh has extensive training in electrodiagnostic medicine and is fellowship trained in the use of fluoroscopically guided spinal injections for cervical and lumbar disorders, ultrasound-guided injections for the treatment of peripheral joint disorders, intramuscular stimulation, which is dry needling, trigger point injections, prolotherapy, and PRP, platelet-rich plasma injections. Dr. Singh earned his medical degree from Baylor College of Medicine and completed his residency in physical medicine and rehabilitation at the University of Washington. Following residency, he completed a fellowship in pain medicine at UW, University of Washington. Dr. Singh is committed to providing compassionate care for patients with a wide range of ailments using a comprehensive approach to diagnosis and treatment. Dr. Singh works with several types of practitioners during the treatment process, including occupational, massage, and physical therapists, chiropractors, surgeons, primary care providers, and vocational and case management services. Dr. Singh also performs many treatments himself, including spinal and peripheral joint injections. Overall, he believes in using the most conservative and least invasive care possible to help restore his patients to their optimum level of functioning. Outside of work, Dr. Singh most enjoys spending time with his loved ones and avidly participating in a variety of recreational sports, including football, basketball, softball, volleyball, golf, bowling, and even kickball. You very proudly boast that you're a 3-time kickball champion, and you're more than willing to recount any stories. So, it's tempting to make this an entire podcast about kickball glory. I am an avid kickball player and fan, but we should probably talk about the physical body, about the human body. So welcome. We're so happy to have you.
Thank you for having me.
So let's dive in. And this is going to be a podcast about the physical body, kind of what goes wrong with it, how we can fix it, and especially in light of hypermobility. We often talk about hypermobility from kind of the metabolic and the chemical and the metabolomics and the genetics, kind of the system-wide things that happen in the organs and the tissues and the cellular communication. But today, let's talk about it in terms of the physical body. So walk us through, when we talk about hypermobility, walk us through kind of the parts of the body that are involved with hypermobility, like bones, muscles, ligaments, tendons. Walk us through what those parts are.
Okay, well, let's start with sort of basics. Human body has 206 bones, and where two bones come together, that's a joint. Mm-hmm. And the glue that holds joints together, so for instance, a joint could be like your elbow, your shoulder, your knee. The glue that holds those joints together are the ligaments. And then the muscles go over that and help you to sort of move by contracting. The key in my practice for what I see with hypermobility is hypermobile people with those connective tissue disorders have loose ligaments. So that puts the joints and muscles under undue stress, and they're more susceptible to injury. Mm-hmm. So a lot of what, I try to do is sort of help pinpoint which particular ligaments are causing the most trouble, and then decide, okay, do I need to work on tightening those ligaments up, for which we have treatments to do that? Or do I need to work on loosening the muscles around the joint to try and sort of take that vice grip off? So it's sort of how do I put the human body back into a normal balance when there may be some pathology due to having loose ligaments, which ultimately leads to loose joints.
Do you see, for people who have hypermobility, do you see a difference in whether tendons are tight or ligaments are tight? Or is it kind of like if you're hypermobile, everything's loose? How does that play out?
Yeah, it's complicated. Here's an example. So let's say the ligaments over your SI joint are loose, okay? Because the SI joint's that joint where your hip meets your spine. It's an important joint, and it's held together by a lot of ligaments. And if you're laying down loose ligaments, that joint can be very loose. And what happens is then the muscles, in an attempt to try to stabilize that joint because the ligaments are loose, they say, okay, well, we're going to contract down. And so they get tight. So for instance, you'll see a pattern of, with the SI joint being unstable, the piriformis gets really tight, the psoas gets really tight, and the QL gets really tight. Some people feel better if you loosen up those tight muscles, but some people won't feel better until you tighten up those ligaments. When I tell people what is the most basic way of thinking about what I'm doing as a doctor from an interventional standpoint, I tell people it's if something's too tight, I try to loosen it. And if something's too light, I try to tighten it.
Okay. And so like what happens over time? Like what happens if somebody has an injury and, what happens to those ligaments? What happens to those muscles? What happens to those tendons?
Yeah, I mean, we have to remember that every person is completely different. So every set of injuries is unique. But if, for instance, you're already loose from a ligamentous standpoint and you have some kind of injury, let's say whiplash, for instance, that's one of my focuses of my practice. Those ligaments can't protect you, so you suffer more trauma to the joints. And the muscles have to then compensate even more, and they end up getting tighter. So you could just make a bad situation worse. When your ligaments are already too loose to begin with, you have less protection from injury.
Do you find like with hypermobility that people have like one joint that consistently goes out or a bunch of joints that kind of go out? I know everybody is different, but like what is the overall pattern that you see for people who come with a condition of hypermobility?
Yeah, it matters what we're talking about when we say that, joints coming out. Because sometimes the joints are just loose, but they don't actually sublux completely or dislocate. The joints that tend to dislocate are typically, for instance, the shoulders. But you can have laxity in the joints and they don't necessarily dislocate, but they're just also not protective. And you get extra wear and tear. The common joints that I see as being problematic are the SI joints, because that's such a foundational joint to the whole spine. And because it's so ligamentous already, SI joint being unstable is a big problem I see. I see a lot of problem with shoulders that are loose, shoulder capsules, joints that are loose. Because of my focus on people with whiplash injuries, I deal with a lot of laxity within the facet joints of the neck. Mm-hmm. So, there's the spinal ligaments are one thing, shoulders, but for different people, a lot of these joints are loose. I mean, you could pick a joint, it could be a problematic in a person. I know a lot of people have recurrent ankle sprains because their ligaments are loose. Mm-hmm. The first CMC joints in the hands can be very debilitating. So the joint where your thumb meets your wrist, that's a big one that can be debilitating. You have people whose knees are unstable. Mm-hmm. I mean, I could start from the bottom and work my way up and probably seen every joint as a problem.
Uh-huh. So then we would just be talking about every joint in the skeleton, top to bottom, or bottom to top. So then when we think about these joints, let's talk a little bit actually about our therapies. We talked about, like when you and I were setting up this podcast, we were going to talk about the problems first, but I think it'd be helpful to talk about the treatments and then go back through for like thoracic outlet or CCI or SI joint issues. So let's talk about you do your evaluation, and we know your evaluation is going to be a mix of like a physical exam, use of a physical therapist to kind of also do a physical exam, imaging. And so then once you find a problem, talk to us about some of the treatments that you use when you find joint injuries. So we can even start with like medications, like muscle relaxants, pain, like walk us through kind of the meds that you see and how you think about them.
Sure. But one of the first things I tell all my patients is my goal is to be as obsolete in your life as possible. Uh-huh. So to the extent that I can point you in the right direction, but not have to be constantly doing things, I think is the best thing. I mean, to create that independence. To that end, if you think of a spectrum starting from nothing on one end and mm-hmm. surgery on the other, first line treatments, I would love for you to get started with, physical therapy, occupational therapy, massage type of thing. So work with a good physical therapist. Are there simple rehabilitative exercises that can get you stabilized, get you back into biomechanical harmony? Mm-hmm. Beyond that, medications have their role. I'm not a huge fan of medications, mm-hmm. but in certain circumstances, of course, they can be good. Now, for instance, if you get injured and you're inflamed, and that level of inflammation is just super uncomfortable, you can consider starting with anti-inflammatories. Mm-hmm. Those are some of the meds I'm the least in favor of, but I understand their role. Mm-hmm. But for me, part of the treatments I try to do down the road are to induce inflammation. But early on, you could start with anti-inflammatories if that's sort of where you're at. You're just super inflamed. Muscle relaxants can have their role. I especially like muscle relaxants at night that help you to get restorative sleep. Mm-hmm. So to that end, I like cyclobenzaprine as a medication. It's also known as Flexeril. At a low dose can help you sleep, because if you don't sleep, you don't heal, right? Mm-hmm. And so anything I can do to promote restful sleep is great. If your body is generally sensitized, there are medicines like tricyclic antidepressants you can consider. Those are good for that's your nortriptyline, your amitriptyline, et cetera. those are good because they also make you drowsy and can also help you sleep at night, but they're good for sort of winding down the nervous system.
Mm-hmm.
I try desperately to stay away from opioids at all times. There is a role and place for those. There is a medication like low dose naltrexone that has shown some efficacy in people, including hypermobile people, for just, pain control. But like I said, I try to stay away from those types of medications.
And low dose naltrexone is not an opiate. It's almost like the opposite. So it wouldn't necessarily be in that same category, but that can be helpful for specifically hypermobile people with like global inflammation.
That's correct. That's absolutely correct. Naltrexone is that medicine you give when people have opioid overdose.
Mm-hmm.
But the idea in these circumstances is how do you bind up that receptor and sort of wind down the central nervous system hypersensitivity? There's a lot of medication strategies for this. And I think medications can have their role. It's not a big part of my practice, but it certainly has its role within medicine.
Can you just briefly mention like the difference between methocarbamol and Robaxin versus cyclobenzaprine or Flexeril?
Yeah, I'm a bigger fan of the cyclobenzaprines than the methocarbamol and Robaxins. Well, one thing to keep in mind is these medications that are billed as quote unquote muscle relaxants, probably for the most part, none of them actually relax muscles. More than anything, they help you to sleep. They're sedatives. I like cyclobenzaprine. It has a little bit of that tricyclic effect. So it's sort of similar to the nortriptyline and amitriptyline. So it's helpful for that wind up. I don't do as much Robaxin methocarbamol. Those are a little bit less sedating. So they're the type of medications you can take a little bit more safely during the day. Mm-hmm. And so I'm not completely against them. Beyond that, my nighttime muscle relaxants, tizanidine can be good. There's a really strong muscle relaxant that actually probably does relax muscles, baclofen. Mm-hmm. Not a huge fan of that, but I see its role. It's very potent. Mm-hmm. It's also very sedating. So just another one of those medication choices people can go down.
Mm-hmm. Okay, so meds. So we've got kind of our meds on board, and we've talked about them like maybe short term or like in a kind of encapsulated time period for a certain goal. Certainly, my experience in primary care was like, oh, you have a backache, just start on NSAIDs or just start them. And then there's really, in physical therapy, but there's not a lot of other, options at that point. So talk to us about kind of where you go next.
Yeah, I mean, you're kind of touching on this. There's different phases of injury to think about in context of all this, the acute phase, the subacute phase, and the chronic phase. I'm booked out so far. By the time you see me, you've got to be in the chronic phase anyway. So that acute and subacute phase typically doesn't get on my schedule. That acute phase is where you can consider the anti-inflammatories and the, hey, just give it time phase. Subacute phase is where I would typically add in modalities like physical therapy, et cetera. By the time you're in the chronic phase, you have to be very judicious with your medication choices because you're not trying to get people hooked on medications for the rest of their life.
Yeah, absolutely. That's it. Yeah. So we're at the point, we're talking about now people are kind of coming to see you. They've seen physical therapy. They've tried some different medications. It was great to distinguish between when you're trying to do an anti-inflammatory in the beginning, when you're trying to do a sedative to help with sleep or kind of calm things down, when you're trying to do a tricyclic antidepressant to get the nervous system to calm down. So let's say none of that is effective. Pain continues. Where do we go next?
Yeah. So by the time they see me, what my role is to sort of figure out, okay, is there something going on that we actually need to treat? In other words, have we been treating the symptom, but not the cause? And that's where I start to approach it from more of an interventional standpoint. And what I tell a lot of people is, listen, if you don't like needles, I may be the wrong person to see because, first step forward, to the extent that we get imaging to try and figure out what's being missed, that's great. Sometimes imaging can be very helpful. Sometimes you get an MRI and you can see a major tear or a herniated disc, et cetera. But during this chronic phase, and by the time people have seen me, they've oftentimes had a lot of the imaging and it didn't show them what's going on. So what I pride myself on is that sort of expertise in understanding the more microscopic injury, the injuries that don't necessarily show up on imaging, but can be verified. And how do you verify an injury that you can't see on imaging? Well, in my world, what I do is I anesthetize areas and see if your pain goes away. So for instance, let's say you have neck pain and headaches, like suboccipital headaches. They go from your neck into your upper trapezius and into your shoulder. And you image it, you get the MRI of the brain, MRI of the neck, you can't see anything. Well, there are certain structures in that area that I can anesthetize, put some numbing medicine over the nerves. And if your headache goes away, I've now proven where your headache is emanating from.
Mm-hmm.
Once you know where something's coming from, now you try to understand the dysfunction within that area.
Mm-hmm.
And it may be that the joint's too loose. So if that's the case, then I would potentially propose treatments to try and tighten up the ligaments around that area.
Mm-hmm.
It could be that you have an irritated joint. Well, for instance, then I might put steroid in the area to try and calm down the irritation in the area and stop that signal from constantly going to your brain. It could be that the muscles are very tight and are irritating the nerves in the area. Well, in that case, I may loosen the muscles up around the area with a variety of treatments like IMS, trigger point injections, et cetera, to say, okay, maybe if we can focally loosen things up, maybe that can take the pressure off these headaches. So that's another one of my sort of areas of interest are cervicogenic headaches, those headaches that seem to emanate from your neck. So that's kind of one way I would approach it, both on the diagnostic side by anesthetizing the area and seeing if your pain goes away. And then on the therapeutic side, trying to figure out why it's that way. One of my favorite things to say to patients is, we try to figure out the what, but then we also got to figure out the why.
Mm-hmm.
What's causing your pain? First question. Why is it irritated? Why is it causing the pain is the other question. And if you don't understand the what, it's hard to figure out the why. And if you don't understand the why, it's hard to figure out what to do about the what. So it's important to me to try and figure out both of those. And to that end, I rely on diagnostic blocks. I rely on the help of good manual therapists who can get in there and tell me if things are loose. Rely on a lot of stuff to try and figure that out.
And then once you know that, what are the treatment options that are kind of like make up your toolkit?
So let's say, for instance, you have, because we're going back to the hypermobile concept, let's say you have a joint that's too loose and the ligaments are they're just lax. They're loose ligaments. The joint's irritated. It's shooting off a signal, causing you headache or neck pain or shoulder blade pain or whatever it is. I oftentimes will use a treatment called prolotherapy. What prolotherapy is you are purposely inducing an inflammatory response to try and tighten up those ligaments. So some people think of it as scarring down the ligaments, but you're really just trying to tighten down those ligaments that are too loose. And if that's fundamentally what your problem is, this is one of the most effective treatments to do something about it, because, nobody should offer you to fuse that area right off the bat. So if there's a much less invasive way of tightening the ligaments up so that looseness becomes normal, that's what I try to do.
What's in prolotherapy? What are you injecting in?
Yeah, so everybody has people who do prolotherapy can all have a different concoction. My concoction is the most basic one, D50 and lidocaine. So it's dextrose, which is like a sugar-based solution, and lidocaine, which is an anesthetic. So it's basically a localized irritant trying to create an inflammatory response. I tell people it's like I'm lighting a fire, so the fire department comes to fix the area.
There was like a little fire there already, but nobody was paying attention to it. So now you're kind of like making it a thing so it's visible, it's seeable.
Yeah, basically I'm lighting the area up, which is I tell people if you're going to go down the prolotherapy route, you have to make 4 mental leaps with me. Mm-hmm. Mental leap number 1 is that I'm going to intentionally cause you more pain. So that's a big one. Like that's right off the bat is a big one to have to make. Number 2, you're not going to be able to take anti-inflammatories to try and stop the pain because remember, I'm trying to create inflammation. Number 3, I can't tell you if it's going to work or not. I'm not a very good manual person. Like I rely on physical therapists to tell me if those little joints are loose or not. Mm-hmm. And then number 4, not covered by insurance. So you have to pay me out of pocket to cause you more pain for which you can't take any anti-inflammatories, and I have no way of guaranteeing you whether it works or confirming for you whether it works. You have to make those 4 mental leaps to go down this path towards this. And many people make that leap. And of all the treatments I offer people, this is by far my most successful. This is the one where I have the best track record. But you have to get over that sort of like, okay, he's causing me more pain. One of the things I tell people is, with steroid injections, I think of steroid injections as short-term benefit, long-term harm. And I think of regenerative injections, your prolotherapies, your PRP, et cetera, as short-term harm, long-term benefit. I'm making you worse so I can make you better in the long run. Mm-hmm.
That's like a no pain, no gain, like Garfield the cat. No pain.
Yes, exactly.
How long do you hurt for with prolotherapy?
Everybody's different. Mm-hmm. And it matters which treatment number you're on, because that's another thing I didn't mention. It's usually a series of treatments. And for me, the typical number is usually 3 treatments. So for most people, they hurt the most during that initial inflammatory phase. And that's typically worse days 4 through 6. So usually there's a little bit of a honeymoon. You might have a little bit of post-procedure pain, but for the most part, it's not that bad. And then the inflammation slowly starts to kick in. So usually there's a day or two where there's a honeymoon period, and then inflammation starts to kick in. And so things then get worse. Some people feel inflamed for 2 or 3 weeks. Most people, it's just that 2 or 3 days in the middle for, days 4 through 6. But everybody's different. I've had people who I do prolotherapy to, and they're like, oh, that was nothing. And I've had people tell me, oh, I was bedbound for, 3 weeks. So there's different kinds of responses. You just have to remember, some people, when they get injured, have a very strong inflammatory response. And some people, when they get injured, don't have a huge inflammatory response.
And everybody responds differently to pain. So some people feel like a physical pain, they can kind of cut that off, or they can kind of move through it. And other people, have negative historical associations with pain, or whatever it is that makes it unbearable.
That's exactly correct. I mean, some people, their nervous systems are very wound up.
Yep.
And a little bit of pain becomes a lot of bit of pain, right? Yep. And some people are sort of very stoic about pain, and they can kind of work through it. I tell people to think of that as the amplifier, right? Your nervous system's like an amplifier on pain. And some people, their amplifier is like way up. So of course, if I cause you more pain, it's going to make it much worse. And some people, that amplifier's not that high, so it's not as bad.
How far apart are these treatments?
I typically do them 3 weeks apart, because first you're going through that initial inflammatory phase. Then there's something called the proliferative phase, as the tissue's starting to get laid down. And I'm waiting for that proliferative phase to start to come down, which is usually around the 3-week mark, before we do it again.
Okay. So people come to you for a pain, like their SI joint, they're having pain. They get this prolotherapy, and then are they just better? Or do you have to re-up it periodically? What's the long-term course with prolotherapy? Yeah,
it's a good question. Keep in mind, once again, this will be a theme I give you, is that every patient's unique, every patient's different, et cetera. But to your larger question, what I tell people about prolotherapy is I say, first thing to do is imagine you're in a boat. It has a hole in it, and it's filled up with some water, right? And maybe it's been filling up with water for days, weeks, months, years, whatever it is. I imagine that prolotherapy plugs that hole for you, right? And for some people, you plug the hole and they immediately feel better. You stabilize the ligaments and they immediately feel better. But for other people, it's the first step in a process, right? So for instance, if we're talking about your SI joint, yes, I've now stabilized your joint, okay? But you have muscles that have been firing off for years that you got to teach them to relax. You've got other muscles that have just shut off that you have to turn them back on, your glutes, etc. You have to turn those muscles back on. You have to do physical therapy to do that. And there are pain pathways that have been lit up for years. And they don't always just instantaneously go, oh, we can just turn off. So there's a lot of neuromuscular retraining that has to come, pain re-education for the brain. But generally speaking, this is the first step to getting you there.
So like the analogy would be with the boat. That's great. So it's like, if you've been bailing for all this time, your body is used to bailing. So even if the hole is plugged, your body is going to continue trying to do that. And it takes, and physical therapy is that retraining. Is that right?
Well, yeah, for some people it's physical therapy. It could be occupational therapy. For some people it's just massage to get the muscles to let go. Everybody's rehabilitative program is unique, and what their body responds to is unique. So I try not to say it's only physical therapy, because there's other skilled practitioners out there. And as you know, the lines are now blurred, right? It used to be physical therapy did the exercises, chiropractic did the popping. Now the physical therapists are doing the cracking and the popping, and the chiropractors are doing the physical therapy exercises. So I try not to think of it as a one size fits all. For most people, for most of my patients, it's physical therapy, but it could be, any number of modalities to get them to where they're trying to get.
And even just to your point, as we were in clinic last Friday, there was a patient who was saying, I was carrying my skis on my right shoulder. I realized, maybe my right shoulder isn't strong enough. I put him to the left. And you were saying, you kind of got around to saying, do you want to talk with pain psychology? Like, is there a way that your body is now so primed and fearful of pain that we need to work on that fear piece? So not even necessarily a physical retraining, but like also a mental nervous system retraining.
Absolutely.
Anxiety around pain.
For some people, that's the ticket. And for some people, it's, I have sort of try and think about people holistically and also what works for them, right? For some people, a psychologist is the worst idea to introduce. For some people, it's the best idea to introduce. Some people have had really bad responses to physical therapy in the past and sort of once bitten, twice shy. And the other thing to keep in mind, and you know this as well as I do, not all physical therapists are the same, right? Sometimes you got to find people the right physical therapist for their body. And so there can be a little bit of trial and error. One of the things I try to do is have as broad of a Rolodex available to patients. So I try to have as many relationships with people as possible so that we can work in an integrated fashion. That's one of the reasons I'm doing this podcast and you and I met. I talked to you, like, this sounds like a person who could be very helpful to me and my patients in the future. I want to get to know her. Hey, please come down, spend a day with me in clinic. Let's chat more about our practices. Let's try to understand each other. Because I think it's important. I don't pretend to be able to offer all the solutions to all the patients, right? So I need to rely on other skilled people and their skill sets to try and help get patients where they want to go.
Yep, absolutely. I absolutely agree. The first teeny tiny private practice I started, decades ago in Seattle I wanted to call it Seattle Health Mavens, as the idea that it could be the network, that not one person is going to be perfect for every situation for every person. So really getting to know the climate and being able to use referral services and know the patient and then know the practitioners and be able to link the right people together. I totally agree. So, and let's just talk a little bit about a few different injuries. One of the things that we talk about with the septad patients who have hypermobility, dysautonomia, mast cell activation, long COVID or Lyme or EBV, these chronic infections, gut issues. We also talk about that there's a higher potential prevalence of something called CCI or craniocervical instability, or even AAI, Atlantic axial instability. Can you talk a little bit about that condition and about if prolotherapy might have a role there?
Sure. The interesting thing with CCI, which is craniocervical instability, it's basically the area between your skull and your upper neck are just unstable, is it can lead to such a variety of symptoms and they can coexist with so many symptoms. It's hard to know. You can have somebody who for the world looks like they have some post-concussive syndrome or Lyme disease or long COVID, all that fatigue, cognitive fatigue, et cetera. And it could all come down to their craniocervical space is unstable. And that leads to poor CSF flow to the brain. That leads to tension and pulling on your lower cerebellar structures. It can lead to so many symptoms that can overlap with so many other syndromes. So it's worth at least exploring. Once you get down to the idea that they have craniocervical instability, then the real heart of the matter is, what are the structures that are unstable such that if you can tighten them up and stabilize them, people will feel a lot better. And one of the things that's interesting is my comfort level from an interventional standpoint ends at C2-3. So in other words, if you think about the spine and especially that upper cervical area, C2-3 is probably the most common area. And if I can stabilize you at C2-3 and that takes care of your symptoms, that's great. And that might be all we need to do. But as you know, there are a lot of ligaments above that. It's a very dangerous area. You have your alar ligaments, your atlantoaxial ligaments, all that higher stuff. That's more dangerous to get to from an interventional standpoint. In those cases, I actually, if they need something interventional, I oftentimes will refer them to a place called the Centeno-Schultz Clinic because they've come up with a procedure where you actually go through the mouth with a needle to get to that upper cervical area. But I think from my standpoint, I like to screen them out for the easier stuff. Hey, can I get you better at C2-3 before I start making you go all the way to Colorado for that? Now, beyond that, there are surgeons who will do a fusion up in that area. Dr. Bolognese in New York, for instance, I think he used to work with your team quite a bit. So there are people who will fuse it. I want to help people avoid that procedure if I can, because I'm not a fan of actually fusing structures. But for some people, that ends up being the best solution. So it really comes down to can we get you better just with therapy alone? If that doesn't work, can something as easy as prolotherapy, but to the C2-3 facet ligaments help? If you have to go beyond that, do I have to send you to the Centeno-Schultz Clinic to consider something, for instance, to the alar ligaments or the atlantoaxial ligaments? And then beyond that, are you so disabled and are we so sure this is the diagnosis that we consider actually fusing the structures?
Okay, so that's Prolo in a nutshell and CCI. talk to us about some of the other treatments that you use, like PRP.
Yeah. So PRP and prolotherapy are kind of cousins of each other, but they're, in my world, they're very different and they're used for different things. But here's the easiest way to think about prolotherapy versus PRP. Well, first, let's start with what PRP is. PRP stands for platelet-rich plasma. That's where we basically take your blood, and we'll usually take about 120 cc's. We spin it down in a machine to just take out all the healing growth factors out of your blood and then inject that into various areas. The way I try to explain the difference between prolotherapy and PRP to people is I say prolotherapy is like I'm lighting a fire, so the fire department comes, and PRP is like I'm just taking the fire department, I'm putting them there. For me, PRP makes sense if you are dealing with muscle tears, tendon issues. Those tend to heal really well with PRP. Or if you're trying to treat the intra-articular surface of a focal joint issue. Beyond that, I like prolotherapy better for spinal ligamentous issues. Let's take the shoulder joint for just as one example. Let's say you have a loose shoulder, like your shoulder's clicking, popping, etc. We get an MRI, and the MRI shows a tear of your rotator cuff. Not so much that you want to do surgery, but there's a tear there, and that might be creating the instability. PRP might be the better choice because that's going into a muscle, right? Let's say I get an MRI arthrogram of your shoulder, and it shows you have a focal labral tear. So there's a tear in the lining. And we think that tear in the line, that very focal tear in the lining, is what's causing your instability and your pain. And you don't want to go and do surgery for it. PRP might be a great option because that's just going to focally go to that area and try to heal that up. Let's say instead, we get the imaging and there's nothing that shows up on the imaging, but when you actually examine the shoulder capsule, it's just loose. The capsule itself and the ligaments around it are just loose, and your shoulder is just loose. There's no tears. There's not anything obvious on the imaging. That's where prolotherapy is a better choice because you're going to get in there and you're going to just tighten up all those ligaments with prolotherapy. So that's kind of a dividing line. If it's a focal issue and you want a very directed treatment, PRP might be the best bet. If it's the whole structure, the whole capsule is just loose, I think prolotherapy is better. So I do both of them. I really like both of them. I combine them into the term regenerative injections. Regenerative injections equals some combination of prolotherapy, PRP, stem cells. And I try to tailor it. Once again, it's not one size fits all.
Do you have a sense? I know you don't do, I think there's someone in your clinic who does stem cells, but I'm curious if you have a sense of the impact stem cells to harvest them or to purchase them, but really to harvest them, is certainly a lot more work than doing a blood draw, out of your arm to get the blood to make PRP. Do you have a sense of the outcomes between PRP and stem cells? Yeah.
I mean, let's start off with the idea that nobody's really studied this to any high effect. So a lot of this is, from the gestalt of my brain, so to speak, and how I think about things. I think of stem cells as a better fit when you're dealing with cartilage breakdown and severe arthritis, for instance, in a knee or a hip or something like that, something beyond where prolotherapy alone is where PRP alone is going to help you. Now we're talking about the actual surface of the joint is worn down and you're trying to sort of build that up. One of the analogies I've heard between stem cells and PRP, and I always screw this up, so I hope I get this right, is stem cells are like the seeds and PRP is like the fertilizer. I think I got that one right. Okay. So they can work in conjunction with each other. One of the main limiting factors with stem cells, as you know, is cost. And it's a much more
invasive.
It's a much more invasive procedure. As you and I talked about in your practice, you guys would get stem cells from the adipose tissue, the fat. In my clinic, my partner gets them from the iliac crest of the hip. So you actually it sounds worse than it is, but you drill a hole into the hip. It's not as bad as it sounds to extract the stem cells. To the extent that one's more effective, I mean, certainly stem cells are probably more effective. There's just more to it. Yeah. So, prolotherapy is, dextrose and lidocaine. I can draw up thousands of units of that, right? Yep. Just on my own in a syringe.
Right.
PRP is harder to get. Stem cells is even harder to get. So each level you're going up in terms of cost, going up in terms of how hard it is to acquire the stuff to do it. And I think it matters the condition for which we're doing it. And the fact that we have all three of them in our toolkit means we can tailor whichever one is the correct one for the pathology we're dealing.
Excellent. Okay, great. So those are all part of that regenerative medicine. Is there anything else to talk about with those that's also in that regenerative medicine space? Like IMS is not necessarily, Botox is not necessarily, right?
No, I mean, so remember we talked about how my gestalt is, how do I either tighten what's too loose or loosen what's too tight? IMS and Botox fill the space of loosening what's too tight. So if you have a muscle fiber that's shortened down, that's when we start to think about IMS, trigger point injections, and Botox.
And can you say kind of what IMS is?
So IMS is intramuscular stimulation. The way I explain this to my patients, I say if acupuncture and deep tissue massage had a baby, it would be IMS. So we're using acupuncture needles, but we're going much deeper into the muscle fiber than you would typically with acupuncture. And we're trying to basically create that more deep tissue massage release of a muscle. So let's say you have a shortened down muscle fiber. You strained your neck, for instance, and the muscle has just tightened down and locked down. Certainly, I'd love for you to just be able to go get a massage and work it out. That might be all you need. But sometimes you got to get deeper than even the best massage therapist can only go so deep within the muscles. You know, hands, elbows, et cetera. You can only get into that muscle so much from the surface. With a needle, you can get much deeper to that level and you get it to just kind of release. So, and people who've had IMS and have felt that release know what I'm talking about, where it's just this immediate release of the muscle. It twitches and then that muscle fiber kind of lets go. And that's what sort of IMS is attempting to do.
And you can do that. Like, do you ever work on TMJ with that?
Oh, yeah. I've done it to the masseters.
Okay.
It's one of my favorite things to do because it's so easy. And then people all of a sudden are like, oh my God, I can just open my mouth up so much.
And so do you have a sense of like, how does that happen? How does poking the muscle, is it kind of like calling the fire department again and that you cause the muscle to tighten up and then it goes, oh, wait, we can relax now. And then it just lets go?
I think it's different on a cellular level than that. It's probably a different concept. I don't exactly know what's going on. I suspect you're getting to those deep stretch receptors and you're just triggering them in such a way that they just get the tension to release.
Okay. And then Botox, talk to us about Botox.
Yeah, Botox is one of the interesting things I do in my practice. And probably we can talk about it more with the thoracic outlet syndrome diagnosis. But just in general, Botox is botulinum toxin. So let's start with what botulism is. I don't know if you ever remember being told, don't feed unpasteurized honey to a baby because they can become a floppy baby. I don't know if that's something we worry about nowadays, but that's what I remember being told. The idea is botulism. There are these toxins. And what they do is they block the junction between a nerve and a muscle. So, you know, a nerve sends a signal to the muscle to cause that muscle to contract, where botulism blocks that junction. So that signal doesn't get through. So if a muscle doesn't get that signal and it's constantly in a state of contraction, it's going to relax down. Now, they've taken botulism and made it into a medicinal form. What some people are familiar with are the use of Botox for relaxing wrinkles down in the forehead, right? That's got widespread use that people understand. So the idea is, how do we harness this toxin in such a way that it can be clinically effective? Now, imagine you have an issue where a muscle just won't release. It's just in a constant state of contraction. The nerve is sending a signal to that muscle and it's just always contracting down. Well, if you can block that signal between the nerve and the muscle, then you can effectively cause that muscle to relax down. Okay,
so then relaxing the muscle, so then things can kind of go back to their previous state, like a more aligned state where you're not so bound up.
That's correct. So the diagnosis I most typically do this for is thoracic outlet syndrome. Not to go off on too much of a tangent, but thoracic outlet syndrome is a diagnosis where the muscles in your neck, on the front of the neck called the scalenes, and your chest muscles, the pectoralis muscles, they get so tight in that area, they're pinching the nerves and the blood vessels. And the muscles are just not releasing no matter what you do with physical therapy, massage, etc., acupuncture, IMS, everything you're doing to try and get those muscles to release, they just won't stay released. That's when I will target those muscles with Botox injections to get them to relax down and then hopefully once you get them to relax down, they stay relaxed. That's where that piece of physical therapy, occupational therapy, massage, et cetera, come in, which is, hey, now that we've gotten these muscles to relax down, we need to rehabilitate that area so that they try to stay relaxed.
Okay, gotcha. I'm trying to think if there's any of the therapies, main therapies that we should talk about that we've missed. I guess the only last one is surgery. Like, when would you recommend surgery?
Yeah, I mean, surgery, let's just start with my goal in life. Let's start there. My goal in life as a practitioner is to help people avoid unnecessary surgeries.
Great.
I think we as a society have become too reliant on surgeries. And this idea that surgery can fix everything, I think, is a bad one.
Yeah.
And the other thing for people to always recognize is there is not a condition that a surgery can't make worse, right? So surgery is not always a guaranteed cure, and it's not without risk that it can make you worse. But that goes with any treatment, including my treatments. My treatments could make you worse. So I'm not anti-surgery. I'm anti-inappropriate surgery. So to the effect of, when is surgery important? Well, depends on what's going on. Let's consider the spine for a minute. One of my favorite diagnoses to treat are when people have a herniated disc, right? And let's say you have a badly herniated disc and it's pinching on a nerve and it's causing you all sorts of pain. What I tell people is there's 3 indications for surgery in those cases. One is uncontrolled pain. No matter what we do, we cannot get you feeling better despite every conservative treatment we've tried. And you just need to get the pressure from that disc off that nerve. Surgery can be indicated. Or if there's some kind of spinal instability, and I'm talking beyond the level of instability, I could do anything with prolotherapy. I mean, it is so grossly unstable that if you don't fuse it together, you risk, badness. That would be an indication for surgery. And the other indication for surgery is progressive neurologic loss. So in other words, if you do not take the pressure off that nerve, you run the risk of permanent nerve damage. So that's sort of the art of trying to figure out who needs surgery as opposed to what I can do. If you're dealing with something that's so unstable, if you don't stabilize it, they risk catastrophic injury, then sometimes they need a fusion. Or you just can't get their pain under control despite everything you've done. Surgery could be indicated. Or you risk permanent nerve damage if you do not take that pressure off the nerve. That could be an indication for surgery as well.
This might be a little bit of a side tangent, but I long ago read there was some study or group of studies that was saying something like, just talking about how the imaging of the back doesn't necessarily predict the level of pain a person experiences. So that if it, when you look at a back, you might say, oh, you should have a lot of, like, an imaging of a back, you might say you should have a lot of pain, and a person doesn't necessarily have pain. Or you can look at a back, imaging of a back, and say you should have no pain, and the person is in tremendous pain. So can you talk about why that is? Why is that?
Yeah. So we have to get away from this idea of MRIs as being this perfect modality to tell us what's going on. MRIs, especially spinal MRIs, are neither sensitive nor specific for injury. MRIs can be incredibly helpful. And in the right hands or eyes, shall we say, such as mine, and the ability to interpret them and correlate them to what the patient's going for, they can be very helpful. One of my favorite things I tell patients is I treat patients, not MRIs, right? MRIs have to be interpreted in the context of the patient and their actual injury and their complaints. Otherwise, you could look at an MRI and be like, oh, that looks like it would cause pain. Let's operate there. But it doesn't correlate at all with what the patient's actually complaining about. And that's the hard part. That's why a lot of incorrect surgeries happen, because if I MRI'd everybody that just walked by the street right now, I would pick up on so many incidental things. I'd be like, oh, that looks bad. That looks bad. And the person's walking around completely pain-free. So really, the imaging has to be interpreted in the context of the actual human being. The other thing I tell people is it's so important to actually look at the images yourself when you have that opportunity. One of the radiologists I talked to told me a saying, 2 radiologists equals 3 opinions. You could have an MRI read by one radiologist and it sounds like the person's about to die. And you read it from another radiologist and it sounds like there's nothing going on. You really have to talk to the patient, understand their symptoms and their complaints, look at the imaging, and see if there is something on a macroscopic visual level that you can see that correlates with their symptoms. But as we talked about early, not every type of pain, injury, symptom shows up on imaging. There's macroscopic injuries and there's microscopic injuries.
Okay.
Macroscopic, that's what you can see and it's obvious. And sometimes I'll get an MRI and it's so obvious that that's what's causing a patient's symptoms.
Okay.
And sometimes you look at an MRI, it looks completely normal, but the human being in front of you is suffering and they're in pain. And it could be something that's more on a microscopic level that you cannot see with our current level of imaging.
Okay. I have long questioned like how radiologists, like that's got to be such a tough job because you sit, in theoretically like a dark little room looking at screens going, yeah, this is that, without knowing anything about the patient or really seeing kind of how they present or how they move their bodies. And so in a lot of ways, it seems like that would be really hard. Like that would be really challenging.
And if you remember me talking about my Rolodex, my Rolodex includes radiologists.
Yeah.
And I will, as best I can, when I can, call them up and be like, hey, this is the clinical picture. This is what I'm looking for. Can we look at this image together? Do you see anything that could correlate with this?
Yes.
And it's amazing how many times when you are actually looking for something, you can see something you didn't see before.
Yep.
And it's not uncommon that I'll read a radiology report and it's read as completely normal. And then I'll look at it, I'm like, it looks like that L5 nerve is being pinched by this far lateral protrusion that the radiologist may not have seen. Let me call that radiologist and tell them. They don't know what the clinical picture is unless you tell them, right?
Right.
And so once they start looking at that more closely, they're like, you know what, you're right. There is a far lateral disc herniation, or there's a little osteophyte right there, and I can see it touching the nerve, and I didn't see it before. And, most good radiologists are not so stubborn that they won't rethink their original read. But that's why you have to have those relationships. That's why I have, 3 or 4 radiologist cell phones in my phone. So I can be like, hey, listen, can we go over this imaging together?
Yep, absolutely. Yeah. And I'm a big fan of that. I often call the radiologist just to be like, I just want to review with you. This is what I'm seeing. Do you see anything that might reflect that? So I totally agree. Okay, so let's talk about a few other conditions. We kind of went over the CCI. I'm super curious about kind of post-fusion or fixation. So we're talking about surgery. Someone's now had their back, L1 through 5, or, they've had fixation, they've had a surgical fusion. What do you see that happens after that? Do you typically see anything, or is everybody different? And how do you treat the things that happen? Like what happens after a fusion or a fixation?
Well, as always, everybody's different. Just want to throw that out there. That'll be our theme for the day.
Yeah,
in terms of fusions, and I want to once again start by, I'm not anti-surgery. Yep. And sometimes fusions are the right thing to do. Something is so unstable, it's causing so much pressure on whatever structures, you have to fuse it. The problem is when you fuse an area, the forces, for instance, in the spine that were normally going through that area now have to go through the other areas with more force, right? Mm-hmm. You've basically taken out one of the areas that were dissipating the force. And you are now more at risk for what's called adjacent segment disease. Mm-hmm. So if you fuse L4-5, for instance, one of the things I'd be keen to looking at if you're having ongoing pain or new onset pain is what's going on at L5-S1, the level below, and what's going on at L3-4, the level above. Because when you fuse that segment, now the other segments are taking on more of the stress. They may be a problem. I don't want to make it sound like I'm saying, well, if you get a fusion, you're destined for a life where the next level is going to be a problem. It doesn't happen in everybody. It probably doesn't even happen in the majority of people. But it happens in enough people to some extent that it's worth at least considering, especially if they're having ongoing pain. And oftentimes they'll tell you, hey, my back feels better, but now I feel this pain radiating into my hip. And I'm like, okay, well, let's look at the adjacent joint. If we fused L5-S1, maybe your SI joint's now starting to act up.
And can you talk a little bit more about SI joints, just in terms of like sacroiliac joint there, talk to us about what that joint is and does.
Yeah, I love the SI joint as an area of treatment because some of the treatments I have to offer it are very effective, especially prolotherapy. But I tell people, first off, we have to figure out if your pain is coming from your SI joint, right? So we're talking about the joint where your hip meets the spine. It's causing this low back, buttock pain, hip pain. So if you're having pain in your low back, your hip, your buttock, and the hip specialist says, well, I don't think it's coming from your hip, and the spine specialist says, well, I don't think it's coming from your low back, it may be coming from the SI joint. And one of the best ways for me to prove or disprove that is to inject the SI joint and see if your pain goes away. Okay. Let's say we have a young, healthy person who has SI pain, pain over that SI joint. Then I tell them, listen, we are at one of two branch points. Either we are talking about a hypermobile dysfunctional joint, usually as a result of trauma and pregnancy included. Some kind of trauma has loosened up those SI ligaments. And that's when we think about prolotherapy. That's when we think about tightening up those ligaments. Or if you have an inflamed, pissed off joint, then you need to probably talk to a rheumatologist, because a lot of rheumatologic diagnoses start in the SI joint, like ankylosing spondylitis, like psoriatic arthritis. And their first presenting symptoms will be in the SI joint. So for instance, let's say the first time you see me, I think your pain is coming from the SI joint, the sacroiliac joint. And let's say you and I both agree, let's start with a steroid injection. And let's say I numb up the SI joint, put some steroid in there, and you're like, oh my God, my pain went away. It felt good for 2 weeks, but then your pain came back. I'm probably going to think that's something unstable, hypermobile, because you didn't have like an overwhelming response from the steroid. You felt better. You felt great immediately after when I numbed it up, but the steroid didn't do much for you. So it's probably not so much of an inflamed joint as it is a hypermobile, unstable joint. So then you and I are going to try and figure out, why is it unstable? Were you pregnant? Did you have, 10-pound twins? Did you slip and fall on ice and fall on your buttock? Were you in a motor vehicle collision? Why is that SI joint unstable? And then you and I might go down the path to prolotherapy after you've done physical therapy, et cetera, first. Let's say I inject your SI joint and you feel great immediately. And then beyond that, you got like 3-4 months of relief. And you're like, doc, that felt amazing. I had no pain for like 5 months. Now I'm thinking, gee, this is an inflammatory condition. And then I'm like, let's go explore the rheumatologic factors. One of the key statements which suggests rheumatologic to me are those people who wake up with a ton of pain, and then as they get moving and walking around throughout the day, it starts to get better. That's kind of the telltale sign where I'm like, okay, you should talk to a rheumatologist. And, there's a lot of good rheumatologists out there that we can talk to. And there's a bunch of test batteries you can run. And I don't try to be the person that orders them all, because I really think at that point, you're best treated by seeing a rheumatologist.
So we've talked about a lot of different things today. We've talked about treatments, evaluations, surgery, medications, PRP, prolotherapy, IMS, Botox injections. Let's just kind of circle back one more time to our hypermobile patients. So for those folks who have tended with a hypermobile body to have pain or stress or dislocations or subluxations or just kind of loose joints, lax joints over time, can you talk a little bit more about them globally? Like, what does the spectrum of hypermobility look like?
Yeah, I mean, it's important to understand that hypermobility is a spectrum. And my favorite term for defining it is not necessarily Ehlers-Danlos syndrome, but it's hypermobility spectrum disorder. And there's a variety of diagnostic criteria to sort of figure out where you fit on this. But one of the things to just keep in mind is you can be a very loosey-goosey, loose jointed person, and it might have caused you no problems throughout your life. Or you could be somebody who's loose and has lots of problems and covers all the spectrums. And you have MCAS, and you have autonomic dysautonomias, and you have CCI, and you have all the different problems people have. So it's important to kind of, once again, not try to apply a one-size-fits-all to this. The screening scale that I use, and probably a lot of people use, is the Baton scale. It's a 0 to 9 scale of hypermobility. Can you flex your thumbs to your volar forearms, extend your little fingers past 90 degrees? Do your elbows hyperextend? Do your knees hyperextend? Can you bend at your low back to put your hands flat on the ground without bending your knees? You get a certain number. And that number can be meaningful or it can be meaningless, but it is something I screen for. So if I have somebody with a bunch of pain and nobody has been ever able to figure out why they have pain throughout their body, one of the things I screen for is hypermobility, because that can be one of the explanatory factors as to why you may have had pain throughout your body that nobody's ever figured out. Then once you decide if their level of hypermobility is pathologic or not, that's when you start to think about the individual symptoms they have and where you can intervene. And that's where a treatment like prolotherapy can be helpful. There is a nice physical therapy protocol to help deal with people who are hypermobile, the Muldowney protocol. So I'll oftentimes refer them to a therapist who does that. But beyond that, then we can start thinking about the focal treatments we talked about before.
All right. Anything else? Any kind of last words about anything we've talked about today?
I think we covered all the broad topics.
Okay. Awesome. All right, great. Well, thank you so much, Dr. Singh, for coming on. And thank you, audience, for listening today with Dr. Virtaj Singh at Seattle Spine and Sport. We've got lots of ways to continue the conversation through Facebook, Instagram, and Twitter. Be sure to share this show with your friends. We welcome your rating and review wherever you get your podcasts. And you can feel free to send topic requests to podcast@centerforhealingneurology.com. We love that you've joined us today to discuss how to make our whole world medicine. We rise or fall together, and we're committed to doing what we can to make as many of us as healthy as possible. And this takes all of us, including you. So thank you for listening, and see you next time.
Partyfish Media. Partyfish Media acknowledges that it operates and records on indigenous Duwamish and Puget Sound Coast Salish land that is still home to the Duwamish tribe. This land is stolen in violation of the Point Elliott Treaty of 1855. We are committed to uplifting the name of these lands and community members from these nations who reside alongside us. For more information on this land, its people, or ways you can help, visit duwamishtribe.org.